2.5 times of the usual maintenance dose is used in order to achieve adequate diuresis. And it's actually compared in a beautiful 2-by-2 comparison between high dose strategy as boluses versus continuous infusion, and both strategies actually resulted in very similar outcomes. Very interesting is that there is a little bit of rise or temporary rise in the creatinine level that wasn't significant, statistically significant between both groups, and this was not really affected in the outcomes in both groups. So the dose study is a very big landmark trial that helped us really understand how to use, at least initially, how to use your loop diuretics in acute decompensated heart failure. My take-home messages from this slide, from this case, is that the initial dose of diuretics in hospitalized patients should be at least 2 to 2.5 times more than the maintenance dose, and this should be given parenterally and not orally. You adjust the dose by clinical response. If there is no adequate urine output in 2 hours, you don't wait for the next dose or the next day. You write for twice a day or every 12 hours. However, you assess in 2 hours. If you don't have a urine output response, you redose again with that same dose that you started with. Do not wait for the next scheduled dose. The response in serum creatinine is very, very important, and it shouldn't always be a reflex action of stopping or reducing the dose. However, it should be a checkpoint in order for you to reassess and reevaluate. The clinical context is important and is key, and it's a really good reason to assess your clinical situation here. And if congestion is still present, you keep going on. Back to the case, if you remember, these are the labs on admission, and these two values, actually this value, the potassium, was very low, if you notice. Just a word of caution: when you're starting to use very high doses of diuretics, you need to pay attention to your electrolyte. And these are little practical tips. If your the goal serum sodium and magnesium should be always checked, and if you have to aim for a goal of serum potassium more than 4 and a serum magnesium more than 2. And you use, this is the equation that we use. We tell our trainees all this, and medical students this, that every 10 milliequivalents of potassium results in a 0.1 millimole rise in potassium. For every 1 gram of magnesium results in 0.1 milligram rise in the serum magnesium. Always use PO potassium for your repletion. I rarely use IV potassium. IV potassium is inflammatory to the veins and has the same rate of absorption as PO, so that's why you always use PO potassium. On the contrary, for magnesium, I rarely use PO magnesium because it causes diarrhea, and I use IV magnesium instead. Next day on round, same case. So you give the 100 milligrams twice a day, either boluses or continuous infusion. And these are the labs. The potassium now is 4.1, the magnesium is 2.1, the serum creatinine is a little bit higher, it's 1.8. So the patient is still short of breath when he walks to the bathroom, or when she walks to the bathroom. The JVD is still elevated to the angle of mandible. The blood pressure is all right, and the patient peed 6.5 liters. 6.5 liters. So what will be your next step? The answer is continue diuresis. Keep going on. Do not stop, do not reduce the dose. Reassess and reevaluate the volume status tomorrow, and note the urine output. الشيش من فتحت خليها مفتوحة، ما تسكرهاش توا. And I have evidence, this is evidence to say that the transient worsening renal failure or increase in the creatinine in the beginning is really not very harmful, actually not harmful at all. These are all data from almost 20 years now that demonstrates this. Let's go to the second case. 62-year-old male who has COPD, not on home supplemental oxygen, EF is 30%, comes in with acute decompensated heart failure, JVD is elevated to the mandible, edema, classic presentation of heart failure on very good medications. And these are his labs on admission. Give a few seconds for them. So what do you want to do? You give IV furosemide, 200 milligrams, with IV acetazolamide, 500 milligrams. You give PO furosemide, 80 milligrams every 12 hours. You treat this patient with COPD, give you nebulized bronchodilators and methylprednisolone, and start doxycycline. IV furosemide 100 milligrams once daily and reassess next day, or them on drip after giving a bolus. What I'm trying to demonstrate from this is that if you notice that the serum bicarbonate was a little high presentation, and this brings us to the adverse study. The adverse study was done and published around a year and a half to 2 years ago, and it really assessed the use of acetazolamide as an adjunct therapy to IV diuretics in patients with acute decompensated heart failure, and actually showed very beautiful results that these patients who received acetazolamide actually had better decongestion and that had upon discharge, and lower length of stay and better urine output during their hospital stay. What is my take-home message here? Is acetazolamide, as we all know, it's a carbonic anhydrase inhibitor, reduces proximal tubule sodium reabsorption, and improves the efficiency and efficacy of the loop diuretics. Patients who have been treated with acetazolamide had more diuretic and natriuresis effect, had a shorter hospital stay, and more likely to be discharged without residual signs of volume overload. And unlike other diuretics, it really does not have a lot of hypotension effect, does not cause electrolyte imbalance and or renal impairment. Do we still have time for the last case, or shall we stop? 5 minutes? Oh, beautiful. I can finish this one in 5 minutes. So this is an interesting case, 53-year-old male, chronic systolic heart failure, EF of 15%, very dilated left ventricle, 7 centimeters, has a CRT, admitted with class 4 symptoms, classic symptoms of fatigue and tiredness. This is his 3rd admission in 4 months, and these are his medications. And we'll note that his valsartan, sacubitril valsartan, was stopped due to borderline hypotension. His vital signs on admission, as you can see, 97/75, with a heart rate of 93. On exam, he appears lethargic, mildly jaundiced. His JVD is elevated to the earlobes, cool extremities, no edema, chest is clear, abdomen is non-distended with right upper quadrant tenderness. These are his labs on admission. You can see his creatinine is above baseline. His baseline is around 1.4. AST, ALT, bilirubin, all are high. He has a high INR. We did not see in the stem that the patient is on warfarin. EKG reveals a biventricular paced rhythm. In the ED, he was given IV furosemide 200 milligrams. حد سمعني وعطاه 200 finally, not 20. And he had 600 milliliters of urine output after 2 hours of observation, and his urine sodium was 30. So give a minute to kind of think about this a little bit. And these are the options that you have. What will you do next? You call surgery, you get a right upper quadrant ultrasound, call surgery and take out his gallbladder, or admit to the CICU and start norepinephrine and start IV cefepime because you're worried about that white count being 10 and maybe the patient has pneumonia. Maybe you can repeat IV furosemide as he had minimal urine output. You want to just do what they did at the dose trial. Or admit to the CICU, give IV furosemide and PO metolazone. Or you admit to the CICU, start him on inotropes, milrinone, IV medobutamine, and PO metolazone. So unlike the first 2 cases, actually this case I do not have a good randomized clinical trial or good scientific evidence to convince you that the answer was to use sequential nephron blockade diuresis, meaning that you will use a thiazide or a thiazide-like diuretic before using your loop diuretic. As you can see here at the right end of the slide, the thiazide diuretics inhibit sodium reabsorption from the distal convoluted tubule, therefore enhances your natriuresis and diuresis. However, this is kind of very important to know. As you can see that the use of thiazides or sequential nephron blockade diuresis with on top of loop diuretics, yes, they enhance diuretic effects. However, it comes at the expense of electrolyte imbalance. So that first slide that I showed you, that practical tips about electrolyte repletion is extremely important to keep in mind. And actually, this is a before we move to the next slide, I want all of you to kind of take a note of the reference below. This is a beautiful paper, a state-of-the-art article in the JAC that was published by Dr. Felker, and talks about all the challenges that you can find in diuretics, and I just took this from his slides. So adding a thiazide or thiazide-like diuretic on top of your loop diuretic actually may make you achieve better diuresis. It comes at an expense, as I said, on electrolyte abnormalities. The dose of the loop diuretic you use and the agent that you use, which loop, which thiazide, what dose, is kind of an area of uncertainty. We really don't know. And also, again, I want to emphasize the clinical context is key. What did you notice about the patient that I showed you? That the patient has low cardiac output symptoms. The patient is impending cardiogenic shock, and this patient really needs attention. He's probably has reached stage D heart failure, and therefore probably using an inotrope is very important. You have to recognize low cardiac output state and address the end organ malperfusion in this case before you attempt anything else. So clinical context is key. And with that, I'm done. Thank you very much.
Thank you very much, Dr. Mahmoud. I'll invite Dr. Mohamed El-Harari. He's a consultant cardiologist. His main domain is heart failure. He's going to tell us about management of heart failure in the presence of a chronic kidney disease.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Very happy, excited to be in this beautiful city of Misrata in this prestige meeting. Thank the organizer for inviting me. Thanks for the chairman for the introduction. Waiting for the slides to come up. Huh?
أنا آسف هو الميكروفون عندي أنا لكن شكله بعيد. I hear. I'll reintroduce him, Dr. Mohamed El-Harari. He's a consultant cardiologist, and his main domain, as I said, is heart failure. He's going to tell us about management of heart failure in the setting of chronic kidney disease. The stage is yours.
لا جاهزة شفت الصبح جاهزة كله تمام خلاص Okay, so the title of my talk is Medical Management of Heart Failure with CKD. No, this is my disclosures. What I'll try to cover is 15 minutes if they don't stop me. Before that is going through the CKD and KDIGO classifications, the interaction between CKD and failure, cardiorenal syndrome, all in brief, or not hopefully. The brain stimulation heart failure CKD patient that Mohamed Abdou adequately covered, but I'll go through a few points just for reminding us about this. Use of guideline direct medical therapy in patient with heart failure with CKD, which also was a difficult problem. The risk of stopping RAS inhibitor, particularly in CKD patient with heart failure, which we tend to do. And RAS enablement therapy, just a quick thing. And then can we prevent heart failure in CKD patients? It's very similar, not that similar from Dr. Mahmoud Abdou covered. This is straightforward case, ischemic cardiomyopathy, known heart failure, CKD, diabetes, CKD stage 3, coming with the classical symptoms of heart failure, edema, etc., etc. Yeah. On very good therapy, including ARNI, MRA, all the four pillars, decent dose of diuretics, bisoprolol, spironolactone. He was a bit distressed, blood pressure on the high side, desaturating a little bit, GVB raise, all the classical signs. This is a straightforward case, really, there's no tricks in this case. Just showing cardiomegaly, congestion, ECG established anterior Q waves, bad ventricle with regional motion abnormality. So this is really straightforward. The lab showed that he actually more than doubled his creatinine and urea, and potassium has gone up from his normal 4.7 to 6.5. His GFR dropped from normal 35 to 20. Troponin excluding acute coronary event, very high BNP, confirming or supporting diagnosis of heart failure. Diagnosis clear, straightforward, acute decompensated heart failure. Does he have CKD? Yes, he does. Does he have acute AKI on CKD? Yes, he does. cardiorenal syndrome? Yes, he does. So it's all of the above. So diagnosed straightforward. CKD is very common in adult population. Us, 15% at least of us people normal have CKD. They don't know about it. Most of them don't know about it. What the definition of CKD? You don't have to have a damaged kidney on ultrasound. It can be structural or functional abnormality of the that's been there for 3 months. So not just slight in your creatinine, just persist for 3 months. We always refer to CKD with the eGFR, which is correct, but we have to remind ourselves that to check for albuminuria. You can have a GFR of 90 with significant albuminuria, and you do have CKD. So it's not only the eGFR. Albuminuria is very important, and or combination. Most of the time it's asymptomatic. It goes without saying, the lower your eGFR, your higher your mortality. The worse your state of your kidney function, the more likely that you will have heart failure. Okay? This is important slide to remind us, which I personally was not used to do routinely until last few years or so, that you have to check for the urine albuminuria. You have to do urine albumin creatinine ratio. It's very important because in itself is an independent risk factor, not only for your renal outcome, progression to end-stage renal disease, dialysis, renal death, but also for cardiovascular event. So if you have the lower your eGFR, the more likely that you will die. The higher your albuminuria, the more likely you will die. And if you have both, then you do worse. Both from not only cardiovascular, but also renal. So it's both. So albuminuria is really, really important. Check for it. It's independent, and the both together are bad for you. Both bad for your kidney, bad for your heart. And this has been reflected in the sort of recent category heat map classification. For risk stratification, people with CKD. So any patient with CKD should have their albumin checked, and based on their how low the GFR, how much albuminuria they have, A1, A2, A3 as mild, moderate to severe albuminuria, then you can put your patient to the low risk, mild, moderate, or high risk of not only for renal outcome, but also for cardiovascular outcome. So very important that we do this routinely. It's easy to do. Cardiorenal syndrome, very simplistic. It's actually dysfunctioning of your kidney or your heart that lead dysfunction of the other one. It could be acute or chronic. Okay? Some facts that you need to remind us each other about this relation between the heart and the kidneys. From the heart failure point of view, nearly 50% of heart failure patients have eGFR less than 60. A third of your patients come with acute decompensated heart failure go and develop acute cardiorenal syndrome. For each 10 ml drop of your eGFR, mortality by 15% from the cardiac point. From the renal point of view, half of the death of CKD patients due to cardiovascular disease, half the death. Half the patient who are actually on dialysis, they will have MI within 2 years of having started dialysis. Nearly 40% of dialysis patients, they have coexistent heart failure. The incidence of developing new heart failure in CKD patients is about 15% per year. So going to our patients, what you will do, a lot of the answers are correct. You correct hyperkalemia and increase the risk. Obviously wrong, as Dr. Mahmoud Abdou, you have to put them on IV, correct hyperkalemia. What would you do with their MRA and the ARNI? Would you stop and restart later on, or you stop and forget about it and replace it with hydralazine and isobutadienitrate? And would you consider adding potassium chelating agent like Patermer or Lokelma? So our patient just to quickly go this, we put him on IV furosemide, 40 BID, we stopped spironolactone, sacubitril, corrected his hyperkalemia appropriately. How did he progress? Next day or third day, he's still edematous. He walks around edematous, but you checked his lab, his kidney got worse and urea got worse. What would you do? A lot of the time, people, what they tend to do, they stop the diuretic, reduce diuretic. Actually, sometimes you put them in fluid, even though they are still congested, which is the wrong thing to do. They give them sometimes fluids. Or would you actually really push further, even though your creatinine are worse? As Dr. Mahmoud clarified to you today, that's what you should do really. What about low dose of dopamine, the renal dose that we used to give long time ago? And this slide's already been shown by Dr. Mahmoud Abdou, but it's really just to emphasize the importance of decongestion. This is a study of 600 patients, acute heart failure with AKI or cardiorenal syndrome. People who did best, as you expect, who become decongested and renal function do not get worse, which are the blue line. But the second group who did best, actually the kidney function gets worse, but they become euvolemic. The one that makes you feel better, which are still congested, but the kidney function are okay, you're happy with, and still got edema, actually it's worse in the black line. So decongestion, euvolemia is important, regardless of the kidney. If the kidney gets worse, as long as they are congested, diuresis. If they get worse, then think about renal replacement therapy. But don't stop or reduce diuretics or give flows just to maintain the kidney function. That's the wrong thing to do. Renal dose dopamine, which we used to do in the past, hoping that this will make the kidney works better and decongestion, it doesn't work. It doesn't work. It's no longer recommended practice. You should not do it. It doesn't work. So what we did with the patient, we actually increased his IV furosemide, we added metalazone. He gradually become euvolemic, the kidney function get better. And this is really common scenario. You push for diuretic, the diuresis, the kidney actually, eventually most of them get better before they go home. What we did when we discharged him, we stopped his RNA and MRA and put him on hydralazine as nitrate, increased his a little bit to 80, kept him on the IMBA and the bisoprolol. Is this the correct thing to do? The problem with CKD patient, if you look at all the heart failure trial, you find the number one exclusion criteria is what? EGFR less than 30. This therefore make it difficult because you say we don't have an evidence-based recommendation to how you treat this patient. And the most common reason that we do not initiate or stop, a RAS inhibitor particularly, is either the hypotension or hyperkalemia or kidney function. But in reality, if you look even this landmark heart failure trial that done donkeys years ago with the ARB or ARNI, which also showed these agents are better than placebo from the heart failure point of view, actually their kidney function, we will continue on the ARNI, on the RAS inhibitor, actually get better. So those actually, even the study who had the RAS inhibitors, enalapril, whatever, or candesartan, whatever, are the kidney function less likely to double, less likely to have renal death when they are on what? On the RAS inhibitor. And the famous paradigm trial, which showed that, Entresto is much better than enalapril in heart failure. In that study, the decline in EGFR was much less on those who are on what? On the RNA compared to enalapril. So they do better when they push for the RAS inhibitor. And there is a recent analysis of the Paragon and Paradise trial looking at the people who what? Because what happened? You put somebody on whatever ACE inhibitor or ARNI and the kidney function gets worse, EGFR drop below 30, what do? You stop, correct? Wrong. Because in this analysis, they showed people who actually EGFR drops below 30 on the ARNI, but they kept them on the ARNI, did better from not only from the heart failure point of view, but also from the kidney point of view. Like they are less likely to go into dialysis worse because you kept them on the RAS inhibitor, kept them on the ARNI in these trials. Now, believe it or not, probably the worst enemy for our heart failure patient drug-wise is what? Spironolactone, correct? That's the one we fear of because it makes the kidney go worse, makes the potassium go worse. And that happened when we had this landmark trial that showed us MRA reduced mortality in heart failure, and we all start doing it. There was association with increased admission with hyperkalemia and renal impairment. But even in this trial, when they looked at the people who kept on the MRA, their kidney actually get better than placebo. So they're all good for your heart, for your kidneys, not only for your heart. Good for your kidneys, not only your heart. Even. So why we should not stop RAS inhibitor? Why should not actually reduce the dose a little bit, doctor? Really, the kidneys are getting a bit worse. Why shouldn't stop it? You should not stop it. But reality, that's what we do. In most cases, we don't even initiate RAS inhibitors because of the fear of renal, renal stenosis, theoretical. Kidneys are not great or potassium is high. And one of the common reasons of reducing or stopping RAS inhibitors is the hyperkalemia. And if patient with heart failure develop hyperkalemia, in most cases, more than 40%, we either down titrate or stop. Not only us, this is worldwide. So that's what tends to happen. But this is not good. Why? Because we know, say from this retrospective of more than 200,000 patients on RAS inhibitor for various indications, whether CKD, heart failure, or diabetes, where the mortality, as you see on the left side, varies between 5% to 37% on RAS inhibitors. If you just half the dose, you double their mortality, the figures get doubled, completely doubled. And if you stop it, you increase, but not by that much. So even just halving the dose, you're doubling their mortality. So really, halving the dose is as bad as stopping it altogether. So do not reduce the dose as much as you can. Not only you increase the mortality from the cardiovascular point of view by reducing or stopping, actually the kidney gets worse. Long term, there is 60 to 74% of advancing into end-stage renal disease, dialysis, because of what? Because you stop their RAS inhibitor or even reduce the dose. RAS inhibitor therapy, this refers to the potassium chelating agent, as you probably, maybe, I'm not sure how available here, it's a bit expensive drug, but it has a role. The butyromere and the sodium zirconium salicylate, the Lokelma, they've been shown that with them, a patient with recurrent hyperkalemia, if you put them in this drug and you they will enable you to keep the patient in your RAS inhibitors, and you can increase the dose. Diamond is a heart failure trial, the Z is for Lokelma. It's been referred to in the guidelines that you could consider this treatment to enable you to initiate and maintain and titrate RAS inhibitor for patients with recurrent hyperkalemia. Can we prevent heart failure in CKD patients? Yes, we can. At least there are two established agents with clean class 1 recommendation, SGLT2 inhibitor and finerenone. In the DABA CKD trial, what they did, patients with CKD, eGFR was low as 25 up to 75 with albuminuria, diabetic or non-diabetic. They give them apagliflozin versus placebo, and they did very well from the kidney point of view. They are less likely to go into worsening kidney function in surgery disease dialysis, but also reduction in cardiovascular outcome, heart failure, hospitalization, cardiovascular death, and death from any cause. And the EMBA kidney showed similar design, similar result with wide
السلام عليكم. تمام. Excuse us for this interruption. Our next speaker is Professor Laila Abid. She's a professor of cardiovascular intervention and imaging cardiology, head of cardiology department, Hedi Shakir Hospital University, Tunisia. Today, Professor Laila Abid will talk about HFpEF challenges in diagnosis and management update. Please, thank you.
Thank you. صباح الخير من تونس الخضراء لكافة أشقائنا وزملائنا ليبيا الشقيقة. شكرا على الاستضافة. أنا فرحانة برشا اللي أنا موجودة معكم في ليبيا. Thank you for this nice meeting. All the organizing committee, Dr. Osama, Dr. Ali, Dr. Zeki, Dr. Osama also, and all the organizing committee. So it's my pleasure to talk this morning about HFpEF, challenging diagnosis and the updates, especially about the treatments. So I don't know if the slides are ready or not. HFpEF is common heart failure. It's about 50% of so it's the most common type of heart failure, and about 50% of new heart failure diagnoses are HFpEF, and the prevalence is increasing, so about 1% annually versus HFpEF. HFpEF is associated to high risk mortality and hospitalization.
for the first time, I thought that the patient has significant tricuspid regurgitation, and the central venous pressure you measure by central line is actually the right ventricular systolic pressure and not the central venous pressure. So why we are enforcing diuresis for such patient?
So the question, the first part of the question was, the patient that I showed in case 1 had no edema, had no crackles, however had an abdominal distension and JVD that was up to the earlobes. And actually, I wrote the case, and this is a case, all 3 cases, by the way, are real life experience from my daily rounds. And actually, my colleague, Dr. Azza, actually asks a beautiful question, and I will rephrase her question, how can we assess volume in patients with chronic heart failure? And actually, this has been studied multiple times, and actually we showed that if you rely on edema and crackles, you are probably really late to the game. And the reason why is patients with chronic heart failure, especially heart failure with reduced ejection fraction, what happens with chronic edema and chronic congestion is that you recruit your lymphatics, your lymphatic vessels, and that's where your interstitial volume escapes to. Lymphatics, as we know, are hidden. Where are the most richest lymphatic system in the body? Is your chest or your thorax and abdomen. Hence, if you notice the question, the stem of the question was written very carefully, that the patient complained of early satiety, gut edema, and orthopnea and bendopnea, and that's where the fluid is. So the fluid hides. You will not, I only see heart failure patients. I'm a transplant cardiologist. I see heart failure patients only in my practice. The amount of patients that I see that have edema is probably 10%. And they are massively volume overloaded. It is not TR, it is not MR, it is volume, straightforward volume. And you assess that by the JVD, and that has actually been shown in some observational studies, so on and so forth. Those patients, you take them to the cath lab, I take them to the cath lab, put a right heart cath in them, do a PA catheter, swan them, you will notice that their aortic pressure is in the 20s and the wedge pressure is in the 40s. These patients are severely volume overloaded. So the bottom line, the answer is you recruit your lymphatics, the interstitial volume goes, or the interstitial fluid goes into the lymphatics, you don't see edema. On the contrary, in acute heart failure, for example, I am known previously healthy and I get heart failure today, the first place where the edema will happen is my legs. You will have leg edema. But patients who are on chronic diuretics and chronic heart failure will not show edema.
We tried to adopt in my institution what's called the Feras score system. The Feras is an echocardiographic diagnosis. It is not only for tricuspid regurgitation, but you can assess the volume overload by the IVC, by the hepatic veins, by the renal veins, and show the waves, and you can judge whether the patient is really have volume overload or not. Do you have any idea?
Yes, these are some non-invasive methods of assessing volume status. Unfortunately, it hasn't been validated. All the clinical trials that have been shown, even the runoff trials, have not been very promising. So at the end of the day, for heart failure patients, you have to rely on your good old JVD. The JVD is up, there's volume. Yes.
I think we can restart, Dr. Laila. مسكين أعصاب.
So, heart failure, especially HFpEF, is common, as I said, and is associated with a high risk of mortality, of hospitalization. So, what is about the pathophysiology of heart failure? I will remind you, the pathophysiology, there is many mechanisms. It isn't only a matter of diastolic dysfunction with the increasing of the stiffness of the left ventricle, but we have an increased left ventricle feeling the pressure, endothelial dysfunction, and systemic inflammation, because in HFpEF there are many comorbidities such as diabetes, such as obesity, hypertension. And as we As you see here in this figure, the obesity, and I talk especially about obesity, is an independent and a significant factor for the development of HFpEF. And for the cardiologists who attended the cardiology meeting of the European Society of Cardiology in London, it was the first time that they presented obesity and cardiovascular disease consensus about the treatment of obesity and cardiovascular disease. I remind you that about 67% of deaths related to high BMI are attributed to cardiovascular disease. The link between obesity, cardiovascular disease, and heart failure, especially HFpEF, is validated. So, and based on this consensus, look here, Tunisia, Libya. Libya is colored in red. Tunisia, orange. So there are the prevalence of obesity is very high in Libya and in Tunisia. You see here all the Arabic countries, the prevalence of obesity. So we should work to reduce this prevalence of obesity and especially the cardiovascular complication and particularly heart failure and HFpEF. So I will share with you two clinical cases of daily practice. Two old patients, 68 years old. They have the same comorbidities, chronic kidney disease and atrial fibrillation, but the first one has hypertension and BMI was 31 kilogram per meter square, and the second one have the same comorbidities but have others, carpal tunnel syndrome and lumbar spinal stenosis. So the question is, do they have HFpEF? And if we look to the guidelines, USC guidelines, ACC guidelines for the diagnosis of heart failure, it seems easy to diagnose HFpEF. To have HFpEF, we should have symptoms or signs of heart failure, dyspnea, edema, and we should have ejection fraction, left ventricle ejection fraction 50% or above. And we should show that these signs come from, we should have evidence that these signs come from left ventricle dysfunction, cardiac structural or functional abnormality, for example, hypertrophy of the left ventricle or enlargement of the left atrium. But I think that you agree with me that in our daily practice, it isn't so easy to diagnose HFpEF. So, diagnosis of HFpEF is challenging. Why it is challenging? Because HFpEF is an heterogeneous entity. There are, that I say, many comorbidities. And the signs and the symptoms are not specific of HFpEF. For example, if I have breathlessness when I climb stairs or when I feel fatigue, I'm not sure that these signs are related to HFpEF. So there isn't specific signs and symptom. And what is the meaning of preserved ejection fraction? Heart failure with preserved ejection fraction. Because my normal ejection fraction may not be the same than yours. I think that you agree. And you should know that the ejection fraction vary depending on the sex, depending on the ethnicity, depending on the age. And I know that you know also that the women ejection fraction is higher than the left ventricle ejection fraction in men, and is getting bigger and bigger when they go older. And so it's very important to know that there is a difference of the normal, of the definition of preserved ejection fraction. Another problem that patients with HFpEF have often many comorbidities that I said, hypertension, chronic kidney disease. Obesity is the most frequent comorbidities. So we have many phenotypes of HFpEFs. And we need tools and tests to have the diagnosis of HFpEF. For example, natriuretic peptides. Unfortunately, in some cases, they aren't reliable they are unreliable to have the diagnosis of HFpEF, but because you know that, and we can have, look here in this study, 20% of invasively proven HFpEF have anti-proBNP normal. That means that we can have HFpEF with a normal natriuretic peptides or with a low natriuretic peptides. Especially in case of obesity, you know here, in case of obesity, we can have HFpEF with normal natriuretic peptide or low, and we propose to lower the cutoff level by up to 50% in case of obesity, and we presume that there is an overlap between natriuretic peptides levels in HFpEF and obesity. So, how can we, in our daily practice, diagnose easily HFpEF in case of dyspnea, in case of sign or symptoms of heart failure? If I have a patient with dyspnea and or edema, and I'm based on the ACC consensus for the management of heart failure with preserved ejection fraction, there are many steps. There are many steps to follow. First of all, you should assess for non-cardiac source of this dyspnea. That means you should see if it's due to a cardiac problem or lung problem or other sources like as anemia. The same case for edema, dyspnea or edema. It could be from the heart, but also from the liver, from the renal failure, and so you should assess the non-cardiac source before saying that it's related to cardiac source. After that, you should apply the universal definition of heart failure, which based on the symptoms and signs caused by structural and functional abnormality. And for the first time, they mention the natriuretic peptides. And if you see here, they mention the difference between cutoff for acute ambulatory heart failure and hospitalized patient for heart failure. And they mention the fact that higher BMI is inversely associated with natriuretic peptides, especially in case obesity. So, just I will remind you for the structural and functional abnormality assessment, it's very important to know it. And you have this table summarizing all the parameters to assess the structural and anomaly parameters to assess the left HFpEF, the left ventricle remodeling, hypertrophy, the EEI ratio at rest more than 9, the anti-proBNP, the pulmonary artery systolic pressure and tricuspid velocity at rest. So you should have many parameters to assess the left ventricular pressure. And I'd like to remind you that we can have HFpEF without left ventricle hypertrophy. Here in 46% we have no left ventricle hypertrophy. Without also left atrial enlargement. And there are the four key parameters to assess left ventricle filling pressure, the tricuspid regurgitative velocity, mitral annular velocity, left atrial mitral flow velocity, and recently the left atrial reservoir strain. When it is less than 18%, it's in favor of high left ventricle filling pressure, and left atrial peak systolic strain now is a marker of atrial reservoir function, and it has shown to correlate with the severity of increased filling pressure. And now there is a new entity. We talk about left atrial myopathy in heart failure with preserved ejection fraction. Even if the left atrium is not enlarged, we can have a functional problem of the reservoir function of the heart failure at the beginning of the pathology. We can do it especially now with the strain of the left atrium. And we talk also about the biatrial myopathy in heart failure with preserved ejection fraction. And if you have biatrial myopathy, generally it's correlated with the severity of HFpEF. And also I'd like this algorithm. It helps us to assess the left ventricle filling pressure especially based on the 4 key parameters, but especially in case of intermediate gray zone, and in this case we have the left atrium reservoir strain. It's very interesting to conclude. So, we apply the universal definition of heart failure. Probably not, we confirm the diagnosis of heart failure, especially we have echocardiography parameters, functional parameters dealing with HFpEF, but we should then assess for heart failure mimics. First of all, we should roll out non-cardiac mimics. That means if there a primary non-cardiovascular entity causing symptom, renal or liver or chronic venous insufficiency, then we should rule out HFpEF mimics. Does the patient's presentation warrant specific diagnosis assessments? That means this HFpEF or heart failure is attributed to, for example, infiltrative cardiomyopathy, like as amyloidosis, hypertrophic cardiomyopathy, pericardial diseases, valvular heart disease. If it isn't the case, in this case it will be HFpEF, and we should identify comorbidities contributing to this presentation. And in this case, we are talking about HFpEF associated with cardiovascular risk with comorbidities such as hypertension, diabetes, obesity, renal dysfunction, and coronary artery disease. Donc, in this case, when we have cardiomyopathy like amyloidosis, we will talk about secondary HFpEF. If we have no HFpEF mimics, especially cardiovascular HFpEF mimics, it will be primary HFpEF, and it is the most common HFpEF in heart failure cases. So, for example, this echocardiography shows as parameter in favor of amyloidosis. So, we have the heart failure. We applied the universal definition of heart failure. We assess heart failure mimics, and we should then assess the likelihood of HFpEF based HFpEF and talk about primary HFpEF based on H2FpEF score. H2 for hypertension heavy patients, obesity, F for atrial fibrillation, P for pulmonary hypertension, E for elder, and F for feeling pressure. And if the score is more than 6, it's highly suggestive of HFpEF. There are other scores, for example, HFpEF score. It's including more parameters, is more complicated, and it focuses on the importance of doing functional testing in case of uncertainty, especially exercise, echocardiography, even invasive hemodynamic measurements in case of uncertainty of the diagnosis of HFpEF. And now we are talking about artificial intelligence to develop scores to identify HFpEF. I think in our daily practice it will be important to have it, even with automatic echocardiography for detection with artificial intelligence, HFpEF. So if I come back to the 2 patients, we have all the echocardiographic parameters of HFpEF, even the H2PEF score is more than 6, so we have HFpEF, but for the first one it will be primary HFpEF. For the second one, it is probably a secondary HFpEF, and we should look for especially cardiomyopathy and infiltrative, especially amyloidosis. So I arrive at a very important chapter about the treatment. We do the diagnosis, but do we have a treatment for HFpEF? Isn't so easy than the treatment of HFrEF? If we look to the guidelines, until the European Guidelines 2021, there is no treatment has been shown convincingly to reduce morbidity and mortality in patients with HFpEF. Until, and we are very happy, we were very happy to have the update of 2023 European Society Guidelines of the management of chronic heart failure, and it was into the first time that we have clearly in class 1 the treatment of HFpEF. We had diuretic for fluid retention. We have the treatment of comorbidities. It's very important, is a pillar of the treatment of HFpEF. you don't forget to treat the comorbidities. But for the first time, we have SGLT2 inhibitor as a pillar treatment of HFpEF. And SGLT2 inhibitor, dapagliflozin or empagliflozin, are recommended in patients with HFpEF to reduce the risk of heart failure hospitalization or cardiovascular death, class 1, and with high level of evidence. And it was due to very large randomized trial, DAPA-HF delivered with dapagliflozin and the emperor preserved with empagliflozin with positive results. There was a great reduction of the primary endpoint combining cardiovascular death and heart failure hospitalization in case of HFpEF. Ejection fraction is more than 30%, that means mildly reduced, and HFpEF. This is emperor preserved, and then we had also delivered with the dapagliflozin, and even if we have the meta-analysis showed the significant reduction of the primary endpoints in patients with HFpEF. But we are very happy to have a SGLT2 inhibitor. Even in our daily practice, it improves its symptoms, but also it reduces the mortality, the hospitalization in our patients. But if we look to the deliver, unfortunately, we haven't cured HFpEF because there is still a residual risk for the treatment of HFpEF. This residual risk, so for our patient, we treat comorbidities, we reduce weight, we give dapagliflozin or empagliflozin. But what else? Recently, so I talk about emperor preserved deliver, and recently in 2023-2024, we have studies with semaglutide, which is a GLP-1 agonist for the treatment of diabetes, but it have an effect on reduction of loss of weight in patients. So semaglutide was tested in patients, in obese patients, in STEP-HF who have HFpEF, in STEP-HF and in STEP-HFpEF diabetes, and the results were very interesting. And recently in 2024, we have finerenol, and with the famous clinical trial FINAR heart HF. So if we look STEP-HF, there was a significant improvement of the functional class of the symptoms of the patient treated with semaglutide in obese patients. And even we look to this pooled analysis of select STEP-HFpEF, STEP-HFpEF diabetes. That means the clinical trial dealing with the effect of semaglutide in obese patients with HFpEF. The results also are very interesting, significant reduction of also not only the functional status, but also the reduction of cardiovascular death and heart failure hospitalization. And we have also promising, interesting results of an ongoing study, phase 3, with another treatment, tizepatide, anti-diabetics also treatment, but it was also efficient in patients with obesity, regardless the fact that the patient is diabetic or not. And finally, recently in August, the final heart HF was presented in the European Congress in London, and this study was evaluating finerenol, which is non-steroid MRA, in patients with heart failure with preserved ejection fraction, without diabetes, and the primary criteria was combining cardiovascular death and total hospitalization for heart failure, and the results were positive with significant reduction of the primary criteria, cardiovascular death and total heart failure. So finerenol, I think that finerenol now is the new player in heart failure treatment, because there are many ongoing clinical trials evaluating this treatment in HFpEF, in HFrEF, dual combination pill, one with SGLT2 inhibitor, and probably if we will have another positive treatment, clinical trials, we'll talk about three-pillar treatment of HFpEF. We are used to talk about four-pillar to treat HFrEF. May probably, I think in 2025 or 2026, we'll talk about three pillars of treatment of HFpEF, SGLT2 inhibitor, but we will have MRA, non-steroid MRA pheneron, and semaglutide for patients with obesity. And this paper presented in European Society of Cardiology, they proposed this algorithm. Probably it will be adopted by the guidelines. How should we treat HFpEF? If we have a patient with HFpEF, the first goals of the treatment is to reduce clinical events, improve symptoms and physical limitation, reduce clinical events by giving SGLT2 inhibitor, non-steroid MRI, finerenone, semaglutide for patients, for obese patients. To improve symptoms is the same thing. If the patient is still symptomatic, we could consider, or if there any situation, we could consider additional therapy, diuretics, if loop diuretics, if there is congestion, MRA in case of ejection fraction less than 55-60% with fluid retention. If ejection fraction between 55-60% RNE, and we could give it regardless of the ejection fraction for women, and we give RB in case of the problem of intolerance or cause to ACE2 RNA. So we are waiting for the guidelines. Probably we will have this new algorithm, and probably that's to talk about sacubitril/valsartan, why we can give it for women regardless of ejection fraction, and in men if we have ejection fraction between less than 60%. So for this patient, if she persists symptomatic, we can add finerenone and semaglutide. So my key message will conclude with this interesting algorithm summarizing the management of patients with HFpEF. So if I have a patient with dyspnea, with edema, with breathlessness, I should confirm the diagnosis of heart failure and not ejection fraction. I said heart failure. If the patient has congestion, you should give loop diuretics. And then you should assess the ejection fraction, the left ventricle ejection fraction. If left ventricle ejection fraction is more than 50%, in this case, we will talk about HFpEF. And then you should exclude HFpEF mimics. Is it a secondary HFpEF, or is it due to problem, kidney problem or liver problem? If we are sure that it's a primary HFpEF, then we should start the guideline-directed HFpEF medical treatment. So we propose exercise for all the patients, SGLT2 inhibitor for all the patients, diuretics agents as needed if congestion, RNE in case of ejection fraction between 50%, 60%, and for women regardless of ejection fraction. MRA, we talk here about anti-aldosterone, and if ejection fraction between 50 and 60%, and waiting for other randomized trial, probably finerenone also will be as I said, the second pillar, and semaglutide, the third pillar for the treatment for HFpEF. And I invite you to read this nice document consensus dealing for the treatment of HFpEF, because as I said, HFpEF, there are many phenotypes, many comorbidities. There is a common treatment for HFpEF such as SGLT2 inhibitor, but we should treat comorbidities and we should give a specific treatment for each comorbidities. So my take-home message are HFpEF is rapidly increasing in prevalence and accounts about 50% of new heart failure cases. HFpEF has a pronounced impact on patient quality of life and is associated with a high risk of hospitalization and death. The diagnosis in our daily practice is very challenging. It isn't very easy in our daily practice to do the diagnosis of HFpEF. It isn't so easy that the HFrEF. And despite the advances in HFpEF treatment landscape, especially SGLT2 inhibitors, there are a lot of unmet need regarding the diagnosis and also the treatment. Thank you for your attention.
Thank you.
Despite technical and technical difficulties we have today, we have a very rich heart failure session with four eminent speakers, and it's my pleasure now to introduce Dr. Feras Badr. He's the director and chairman of the Advanced Heart Failure Program at Cleveland Clinic Abu Dhabi. And prior to his current role, Dr. Badr was the medical director of the Heart Failure Program and director of the Advanced Heart Failure and Transplant Fellowship at the University of Utah. Beyond his extensive experience in the US, Dr. Badr has made a significant impact in the region by helping to establish advanced heart failure program for Kuwait's Ministry of Health. I personally learned a lot of him, and we are fortunate to have him today. Dr. Feras.
Assalamu alaikum wa rahmatullah. Thank you very much for the invitation once again. So we talked about establishing heart failure programs yesterday and what we need to build that specialty in any given healthcare system. I hope you leave this conference with the understanding that it's essential to start building heart failure clinics. Heart failure clinics as championed by physicians and nurses. So we manage heart failure patients better. This is usually followed by following these patients on the inpatient side, so we manage them better while they're hospitalized, like we heard this morning, by making sure they're not leaving the hospital while they're still congested, not getting chronic kidney disease, as you heard from Dr. Mohamed El-Harari, and of course, in line with the guidelines and clinical studies, whether their heart failure with reduced ejection fraction or preserved ejection fraction, as you heard from Dr. Laila. So my role today is to take you further. My role is to take you today through the journey if patients are worsening with heart failure. So now we did all what we could do with medications, with simple devices that you will probably hear about during the course of this meeting. And now patients are still progressively getting worse. What options do we have for these patients, and how can we tell that they're actually getting to that stage? Remember yesterday I said the heart failure clinics are to treat patients well so they do not worsen, but they're also responsible for referring these patients if they do worsen. Okay, let's take a case. This is a 70-year-old male patient with a past medical history of hypertension, hyperlipidemia, with an established cardiomyopathy who presents to the heart failure clinic for further evaluation and management. The initial echocardiogram revealed an ejection fraction of 35%, dilated ventricle but not terribly dilated, 5.6 centimeters, mild to moderate MR. The patient was on carvedilol, enalapril, spironolactone, aspirin, clopidogrel, and atorvastatin. We uptitrated carvedilol as much as we could and then switched to sacubitril valsartan. We uptitrated that as much as we could, and then we added empagliflozin, basically following the guidelines for management. We then sent the patient for CRTD placement because of the left bundle branch block. In the next 6 months, the patient was admitted 3 times with acute decompensated heart failure. His echo revealed a change in the diastolic diameter from 5.6 to 7.1, so more remodeling now of the left ventricle, and a drop in the ejection fraction to 20% with moderate MR and TR despite maximum guideline-directed medical therapy. Cardiac MR revealed no ischemia or viability, but very large scar. This is the echocardiogram, very bad left ventricle. This is the MR, and this is it in short axis showing the evidence of the old LAD infarct. So during this period, we only managed to get carvedilol to 6.25 milligrams twice daily. As you know, the target dose for carvedilol in heart failure with reduced ejection fraction is 25 milligrams twice daily. And sacubitril valsartan to only 100 milligrams twice daily. Again, the target dose is 200 twice daily. And the volume status continued to be very labile. Patient continued to have progressive cachexia. We decided to evaluate the patient for advanced heart failure therapies. It was clear that the patient is progressing despite everything that we're doing. This is another similar graph to the one I showed you yesterday, but this highlights in a little bit more depth what happens during the course of heart failure patients. As they're diagnosed, they could, of course, have sudden death, which is a complication we try to avoid by putting them on these medical therapies and then sending them for defibrillators if their ejection fraction remains low. They can have continuous decompensations, and with that, they progress and their prognosis becomes worse and worse. As their prognosis becomes worse and worse, we start to consider them more for advanced therapies. And if they're not candidates for advanced therapies, then we start thinking about palliative care. Palliative care in patients who are not candidates for advanced therapy is appropriate for these patients too. You've heard this already. This is the summary of heart failure management at the medication and device level. These are the fantastic four for heart failure and reduced ejection fraction. And then, of course, the concept of individualization is very, very important in heart failure management. We talked about looking at your patient, deciding whether this patient now is a candidate for additional medical therapy. For example, those who continue to be tachycardic by guidelines should be on ivabradine. Those who continue to have high blood pressure and they're of African descent can benefit from hydralazine nitrate, etc. But the key thing is having people on these four pillars, and if we manage to have patients on these four pillars, then we've done a great job. Devices are also important. But once you have patients on all of this, and you treat their anemia to improve their functional capacity, you can refer them for mitral clipping if their MR is very disproportionate to the ventricle. All of that is done, but patients are not improving. So, what are the reasons for not being on maximum doses of medical therapy? Let's say you're not able to achieve this. It's usually the false perception that the patient is stable. The false perception of adverse effects like blood pressure or renal function and electrolyte changes. And of course the transition. Most of the time when patients are discharged from the hospital, that's where their care is disrupted and they're not treated properly with medications. So what defines a stable heart failure patient? Well, the patient has to have obviously low mortality, low morbidity, and then good quality of life. If you have these and you know for sure that they're available in your patient, then perhaps the patient is stable. But this is very hard to achieve in a heart failure patient. If that's stability, then let's just agree on what's unstable. And of course, the patient dies, that means they were unstable. Heart failure hospitalizations represent a form of instability. Frequent emergency room visits is a form of instability. Frequent outpatient visits that are not scheduled, it's just because the patient is not feeling well. Frequent outpatient adjustments, not titrations, but adjustments, because patients are symptomatic either because of their disease or because of side effects. And of course, just how bad the physician feels about the patient. So the presence of multiple bad prognostic factors in the patient that makes us have this bad feeling about the patient. And of course, the bad feeling by the patient, meaning the poor quality of life. So deciding that the patient is stable requires a lot of information. Clinical, functional, biological through testing and biomarkers, structural through imaging, and of course hemodynamic, because at times we only decide that the patient is doing okay by measuring their hemodynamics. Like I said before, this patient was admitted multiple times, so frequent hospitalizations is a very bad prognostic sign. Recurrent hospitalizations mean automatically worse prognosis in heart failure patients. Keep this in mind. If patients have persistent low blood pressure, persistent kidney dysfunction, and inability to titrate their medications to target doses, this is a bad prognostic sign. So before I move forward, let me introduce you to another classification above the classifications that you know in heart failure, the NYHA classification, the ACC stages. The Intermax profile is the profile that we use to classify patients as they're progressing in low output, and we're looking at them as candidates for support. So that would range from the worst case scenario, which is the critical cardiogenic shock, the crashing and burning patient, Intermax 1, and then of course progressive decline on inotropes, then stable but inotrope dependent, resting symptoms, and so forth. This classification makes us look at patients in the context of needing support beyond what they're now being supported with in the form of medications and just simple devices like CRT therapy or even structural interventions in the form of clipping. So the ACC tried to kind of guide people to tell that patients are becoming unstable, that they're heading to the direction of advanced therapies. And they gave this the mnemonic of, I need help. I need help just gives you an idea that this patient is worsening and should perhaps be considered for advanced therapies. So I for requiring inotropes, N for worsening NYHA persistently in the 3 or 4, E for end organ dysfunction, especially renal dysfunction, low ejection fraction. Defibrillator shocks are very bad. If your patient starts having defibrillator shocks, that's usually a very ominous sign. Hospitalizations, like I mentioned before, persistent volume overload, like we heard from Dr. Mahmoud, and then of course, persistent low blood pressure and inability to up-titrate medications. All of these are signs that the heart failure is now progressing to where you need to push this patient towards finding an outlet through an advanced heart failure program so the patient can perhaps benefit from the advanced options. The European Society of Cardiology came up with a similar classification. So what are the options for these patients once they are at this stage? So now we all agreed that the patient is at an advanced stage. What are the options? You can treat the patient with inotropic therapy for palliative care purposes. You can refer the patient for a ventricular assist device, or you can refer the patient for heart transplant. These are pretty much the options. So if you look at the guidelines regarding advanced heart failure, the first thing that the guidelines recommend is to refer the patient to a specialty program. So we talked about heart failure clinics. They're very important. But a key responsibility for these clinics is referring to advanced programs when patients are deteriorating. This is the top recommendation. This is pretty much the main class 1 recommendation for these patients. Now, when it comes to inotropic therapy, it's very clear. If you have the patient for inotropic therapy because they're waiting for a definitive therapy, like an assist device or transplant, it's okay, it's class 2A. You can use it for palliative care, knowing that there are no options for this patient at the advanced level, but you shouldn't use inotropic therapy just chronically, whether it's in a continuous or intermittent fashion as part of your management of heart failure. This is a class 3, which means harm is more than benefit. We abandoned chronic inotropic therapy a long time ago. I still hear about patients coming every now and then for intermittent inotropic therapy, but this is really not proven to be useful. In fact, it's proven to be harmful. So when we use inotropic therapy as a bridge while we're waiting for an assist device to be placed or for transplant, sometimes we give patients a little bit of waiting time while they're waiting for an organ to become available. We either use dobutamine or milrinone for the most time. There are some differences between the two, but most importantly, if your kidney function is bad, it's better to go with dobutamine rather than milrinone, because milrinone can accumulate a lot in renal dysfunction. And when there is significant pulmonary hypertension, we prefer milrinone because it has an added pulmonary vasodilatory abilities. What about mechanical circulatory support? It's clear. If you have patients with advanced heart failure and they're candidates for mechanical circulatory support, you can refer them for mechanical circulatory support for one of specific indications, either as a bridge to transplant. So this is when patients get a pump, an artificial heart pump, as a bridge to transplant, because they are going to be on the transplant waiting list. As a destination therapy, they're not candidates for transplantation, and they're just going to get this device to live with it a much better life than the life that they're currently living with in heart failure. And very rarely we use it as a bridge to recovery, only in specific centers around the world where the device is placed and then it's removed after the ventricle recovers. And of course, as a bridge to candidacy, this is when patients have a potentially reversible cause, or potentially reversible contraindication for transplant, and we place the device to see if that reversible contraindication goes away over time or not. For example, smoking or drug use or alcohol or something similar. So the first use of a total artificial heart successfully was back in the 80s. This was actually done at the University of Utah where I trained. It was labeled as a medical miracle at that time. And it kind of gave us an idea that potentially devices can compete with transplantation to help patients with advanced heart failure. This was the initial generation of these devices, huge pump sitting in the abdomen, connected to the apex on the right side here of the screen, and then of course to the ascending aorta. These devices were pulsatile, they were loud. When I was in training, I could tell that the patient has a device when they walk through the clinic because of the noise of these devices. And of course, they required anticoagulation and ended up with a lot of problems. But when they were compared to medical therapy, they did much better than medical therapy over a period of 2 years. So again, they emphasize that if the technology advances, we have hope that these devices could do something for us in parallel with heart transplant. That first generation moved into the second generation, the concept still being the same. You have a device connected to the heart with a cable coming out from the skin. The cable connects to the controller, and the controller is connected to 2 batteries. Now, the second generation was a much lighter device. It was silent, and it was much more durable. Instead of lasting for a couple of years, now the devices were lasting for 5 to 10 years. And then we moved to the third generation of devices. So instead of the axial flow on the top, we moved to a centrifugal flow. But the technology changed so that the motor in this device was completely magnetically levitated. So the actual motor is carried in a magnetic field. There's no friction. And because it's carried in a magnetic field, it resulted in significant less problems like we had with the second generation or the third generation. This is the largest trial in these devices, and it compared the second generation to the third generation. It's called the Momentum trial, and the Momentum trial showed that there was better outcomes with the third generation compared to the second generation. Recently, we had the 5-year outcome data for this third generation device, and believe it or not, the survival at 5 years is about 60%. So you're taking a patient with a 1-year survival of about 50%, and now with these devices, this 5-year survival is about 60%. Significant improvement in technology with significant improvement in complications like thrombosis or bleeding, all of the issues that we used to have in the first or second generation. So in the initial trial, as you can see here with this pinkish line, had a survival of about 24% at 2 years. When we did the HeartMate 3 Momentum trial at 2 years, it was 83%, pretty much matching transplant outcomes at this early stage of their use. So when we have a patient coming in with a need for an assist device, I look at them from one important perspective. Do they have an indication for a chronic device or not. If they do, like we already evaluated them and they're candidates for transplant or destination therapy, we go ahead with one of the surgical devices, which is essentially the HeartMate 3 as the only available device right now, the one that I showed you as the newest third generation device. But if the patient is coming in a crashing fashion and we don't yet know whether the patient is a candidate for anything like transplant or even destination therapy, we go with a short-term device. Short-term devices are the devices that we can place surgically or percutaneously in the cath lab, like Impella or ECMO. And then once we have the short-term device and the short-term device can switch to a long-term device if we study the patient and we realize that the patient is a candidate. But sometimes the patient can recover and we can take the short-term device out, or the patient can worsen and then we decide that the patient should be a palliative case. Transplant first took place in South Africa in 1967 by Professor Bernard. Like I told you yesterday, in our program we started transplant in 2017. Again, this would be the ultimate option for your patient with advanced therapy if the patient is a candidate. So like I showed you before, chronic inotropes are only for palliative care. The real options are assist devices, either as a bridge to transplant or destination therapy, but ultimately, if you can get the patient to transplant, this is really the gold standard for advanced therapy right now, because the survival at 10 years is about 70%. Remember, the devices are matching what transplant is doing, but maybe up to 2 to 4 years. At 5 years, the survival with the devices now is about 60%. Transplant gives you a survival of about 70 to 75% at 10 years, which is impressive. Guidelines are clear. If patients are candidates for transplant and can be listed for transplant, they should be referred to a transplant program to have that transplant done. The key thing here is that when we work these patients up for these advanced therapies, we go through an extensive process, a process that involves not just cardiac evaluation, but a whole systemic evaluation with pulmonary, abdominal, cancer evaluation, psychosocial evaluation, and then we go through a complicated workflow that our coordinators basically coach, and then that process usually scheduling so many tests and arranging so many appointments before we decide that the workup is complete and we can discuss the patient for candidacy of these therapies. After we do all of these tests, we discuss these patients and we decide whether they're candidates for transplant to be on the transplant waiting list or they're not candidates for transplant. And then the second question becomes, are they candidates for assist devices or not? If they're candidates for assist devices, we place them on assist devices. And if they're not candidates for assist devices, we just basically agree that they're not candidates for anything, and then we talk to the patient and their family about this. So back to our patient, as part of our evaluation, we did a cardiopulmonary exercise test, and the maximum oxygen consumption was 10.1 mLs per kilogram per minute. Creatinine clearance was 32. We did their hemodynamics, and their PA pressure was elevated. The cardiac index was low. And then, of course, the pulmonary vascular resistance was high. In these patients, we sometimes use vasodilators to see what happens to the hemodynamics because we need them to have a reversible pulmonary hypertension before we move to advanced therapy. And just for your knowledge, we refer to the transpulmonary gradient as the mean pulmonary artery pressure minus capillary wedge pressure, and we calculate the pulmonary vascular resistance, which is very important in referring these patients to therapies, as the transpulmonary gradient divided by the cardiac output. So ultimately, we sent our patient who is 70 years old for an assist device. The patient got the HeartMate 3 and is doing very well with the device as a destination therapy device for him. He's completely independent. He drives, he goes to his farm, and he travels and is living a very good life with the device. So advanced heart failure is associated with significant mortality and limited therapeutic options. Advanced therapies are still underutilized. The goal from referral to advanced therapies is to significantly impact the prognosis of heart failure patients. Basically survival, morbidity, as well as quality of life. Clinical, biological, imaging, and hemodynamic factors will help you identify advanced patients. Keep that in mind as you look at your patients. Try to remember the I need help guidance. Advanced heart failure therapy should be individualized based on patient characteristics and excluded if the patient's prognosis is impacted by something else other than heart failure. Thank you very much.
Thank you, Dr. Feras, for this excellent presentation and tackling the problem of worsening heart failure and the advanced therapy. And now we will open the session for questions and to the audience. Maybe we start, I would like to start with Dr. Mahmoud Abdou, if you allow me. Dr. Mahmoud Abdou is here.
He's hiding. Mohamed El-Harari is hiding too.
Yes. No, it's a simple comment and simple question about, improving the condition, although there was advanced heart failure therapy, and improving of condition in heart failure is crucial. And sometimes with the use of diuretics, sometimes the diuresis is not enough. So, do you think that self-training of the patient for self-adjustment of the diuretic therapy, it may help regarding that they will learn about their symptoms and signs, they will learn about the weight, measurement of the weight, and so on, clinical advice. So by training the patient, maybe, and you are an MRA there, maybe it will help to tackle this problem.
Absolutely, you're absolutely correct. And education and patient education is extremely important and crucial with patients with chronic heart failure. This is a disease, this is not tonsillitis or an upper respiratory tract infection that you give an antibiotic for 2 weeks and it goes away. This is something that they're gonna live for the last day of their lives. It is not a treatable, it's not a curable condition, it's a treatable condition. And with empowering the patients and involving them in their care by proper education and patient-centered approach, actually you're able to achieve very successful results. I've have a lot of patients who have ejection fractions of 10% within a dilated ventricle of 7.5. They haven't seen the face of the hospital since their index hospitalization. One thing that is very important is the use, that's why your knowledge of loop diuretics and how you decongest the patients, how to titrate your medical therapy, guideline medical therapy, awareness of symptoms, worsening symptoms. These are extremely important things. One thing that you can utilize is the appropriate utilization of loop diuretics. Nowadays, in the United States, we have subcutaneous furosemide, it's called Furosix, which sometimes in these patients who require ultra mega doses of diuretics, you can give them a supply of subcutaneous diuretics and they can use it at home. So absolutely, the education of the patient and awareness of symptoms is extremely important. You're absolutely right.
Thank you, Dr. Mahmoud.
I'll take the question. I'll give it to you after. Thank you for the excellent talks, all of you guys. It's amazing, and we're happy to have you all. A question about, I'm an interventional cardiologist, about revascularization. It's very important. I have seen a few days ago a patient with low ejection fraction was managed, but there was no cath done. I cathed him, 3 vessel disease, stented him, and he feels much better. I have seen lots of patients also before, and as you know, the ejection fraction improves, symptoms improve. So the concept of revascularization and proper revascularization is very important. My question to you guys, or Dr. Abdou, how frequent you send patients for cardiac angiography, especially for HFpEF and also for, obviously, for HFrEF. And do you follow them after that? Do you ask for another revascularization, or do you ask for another cardiac angiography? Are you satisfied with the results? And what's your approach for this, for all those patients? Dr. Abdou, you go ahead.
Well, that's this topic of our next session, which is the debate, the highly anticipated debate about revascularization and ejection fraction. However, Abdul Ghani, one thing I'll tell you is that in the era of 2024, like what we knew 20 years ago, revascularization in heart failure and ischemic cardiomyopathy has taken a back seat a lot. And there's not a lot of convincing evidence, at least in my eyes, that revascularization actually improves outcomes in patients who are asymptomatic, who do not have angina. So, these patients are sick, and, unless you have a lot of awareness and really be very tough on your guideline-directed medical therapy, revascularization in the absence of symptoms of angina and or in absence of left main disease or proximal LAD, I think it's kind of a little taking a back seat, at least in my eyes.
Well, maybe we'll hear from Feras. What do you think, Feras? Especially heart failure, symptomatic LV dysfunction.
I don't know. It sounds like we'll start the debate here. Mahmoud mentioned a key word. He said absence of symptoms. In my opinion, when patients present with new heart failure, they're usually presenting with something, either acute coronary syndrome or heart failure symptoms. And I'm not sure if we're addressing the same thing. So if patients are presenting with heart failure, with or without angina, but they have heart failure symptoms, in my opinion, and based on at least the randomized evidence that we had from, is not so perfect, but reasonable, stitch trial, patients benefit from revascularization. The problem, of course, with the stitch trial is that it's a debate itself because of the way it was conducted, the mode of viability testing, and all of these things. And I think collectively the evidence is giving heart failure patients complete revascularization, provided they have some clinical symptoms presentation. So they're either presenting with heart failure or with angina, is beneficial in these patients. That's how we approach these patients. Now, do we do viability with MRI testing? We sometimes do it, but we would be doing it with a tendency to revascularize. Unless we see that there is absolutely no benefit, the patient has complete Q waves, it's all scarred, the walls are dead, our tendency is to revascularize these patients.
Thank you all for your excellent presentations. Again, my question to Dr. Mahmoud Abdou. Actually, I have two questions. First question is, how do you deal with the hyponatremia that is associated with massive doses of loop diuretics? This is one question because we are faced daily. The second question, can we combine acetazolamide plus metolazone, yes. Metolazone, acetazolamide in addition to loop diuretic.
Yes.
This is the second question.
Yes, unfortunately, there's not a lot of really solid randomized clinical control trials that will tell you how to manage hyponatremia in patients with heart failure. Now, you have to be very, very careful when you approach hyponatremia and heart failure, because hyponatremia and heart failure is an independent risk factor or indicator for poor prognosis. So if you see that, really your antennas should be up. You're really, really looking for reasons to kind of see if this patient is really stage D heart failure. Now, you know, it can be, this statement that I just said can be confounded by the utility of loop diuretics and aggressive diuresis because you're causing natriuresis, so your sodium level is low. There's ways to mitigate that, you know, especially if this patient is still congested, the patient is in the CICU or under your care in the hospital. Utility of hypertonic saline, utility of something like tolvaptan, things like that you can use, or sometimes even folks use urea and urea tablets and so on and so forth. Those things are kind of more of clinical practice, expert level evidence, not really randomized clinical control trials. Now, the second question that you have was about the utilization of acetazolamide, thiazide-like diuretic, and a loop diuretic. And yes, I use it all the time, especially if the patient is very, very volume congested and the patient is using chronic diuretics at high doses. And of course, you know, their lab work justifies that. You know, they have a high bicarbonate, and you know, really when you're getting to that level of using 3 agents with high doses, you really need to be very meticulous with your electrolytes because this is very important. These patients are living on an edge. A little bit, a whiff of potassium around 3.9 can lead the patient to VT and you can lose the patient. So yes, I use it all the time, the triple therapy, and you know, I will get a phone call from my pharmacist and saying, hey, Dr. Abdou, are you sure you want all this? I said, yes, give it to him. Let him be.
Thank you. Thank you for the fantastic panel discussion. I'm Anas Darmouh. I'm a chest physician, and I work in Misrata Medical Center. I have a number of questions, if you don't mind me. And the questions are not to anyone in specific, but the first question is, what is the utility of serial pro-BNP measurements in inpatients admitted with heart failure? And the second question is, we very often go around heart failure patients.
No, we'll get Mohamed El-Harari here too. He was very comfortable in the chair. There's no value for serial NT-proBNP measurement. It's valuable when you admit patients for the diagnosis and before discharge. Serial measurements during admission has not been proven useful.
Thank you. The other question is, we very often see patients admitted with complex medical problems, including heart failure. And the practice in Libya is that we see doses of furosemide of 20 milligrams 3 times a day, a total of 60 a day. Is this something that you actually practice outside of Libya? Do you have any advice with this regard? And the final question.
The question is, sometimes people come into the hospital and they're on 20 milligrams of furosemide 3 times a day. This is their oral home regimen, right? Oral regimen at home?
No, these are inpatients. Inpatients with complex medical problems, either in medical department or in ICU. And we very often see minute doses of 20 milligrams 3 times a day on 20 milligrams or something like that.
Do you agree with just using low doses?
Okay, I mean, the aim is decongestion, so evolemia. If you are happy they are evolemic, clinically, hydrologically, whatever, and you should actually, the aim actually, at the end, you minimize the dose of diuretics once they are evolemic to enable you to introduce other, guideline therapy. So diuretics as the class 1A indication for congestion, they're not for prognosis. So if the patient is congested, yes, you have to increase those diuretics, TID or increase diffusion or increase the dose, add thiazide-like diuretic until become evolemic. When they're evolemic, then your aim is to reduce the diuretic and push the other 4 pillars.
Dr. Harari, I think the message I'm trying
excuse me. I'm sorry, we're very short of time. We will allow 1 or 2 questions to Dr. Laila, and then we'll end the session, please.
Okay.
Yes. We will do it. We'll take one with my phone too.
Assalamu alaikum. Thank you very much to the 4 pillars of heart failure for these very nice presentations. My question, and it's actually something that we see a lot, unfortunately, in the practice. You did mention reducing or stopping the ARNIs or RAS inhibitors when patients' RFT deteriorates. One thing that we see a lot is stopping them when blood pressure is low. So this is my question. Is there a low blood pressure when patients have significant reduced ejection fraction? And do you recommend like reducing or stopping the dose if they are asymptomatic? Because sometimes it's just because the blood pressure is low, we find that the patient, they've stopped. I mean, they're clinically okay, but they go see some doctor and they say, you have hypertension, we need to stop this. So your advice, thank you.
Okay, thank you for this interesting question about hypotension. I think that there isn't a cutoff for hypotension. We should take off about the symptomatic criteria of hypotension. See, if our patient has hypotension symptomatic, we are invited to decrease or stop the treatment, but we can't have patients with 70, 80 millimeter mercury well tolerated, but we can't find also 90 and 100. And so I think we should, the decision to stop or to keep the treatment depends on the correct symptomatic or not.
Thank you very much. I think we end.
One little question. Please.
One more question too.
My question is regarding uses of ferric carboxymaltose in HFpEF cases. We know it is a very important drug in HFrEF. So what about the use of ferric carboxymaltose in HFpEF cases?
Sorry, use of what?
Ferric carboxymaltose. Iron.
This is another debate.
You want to take it? Yeah, you go. In short, so lots of data, mostly on functional and symptomatic improvement, no survival benefit, some conflicting studies now, but the recommendation based on the guidelines is if you have a low ferritin of less than 100 or between 100 and 300, but with low saturation of less than 20%, you're supposed to give people IV ferric carboxymaltose for this functional improvement, symptomatic improvement, and decreased hospitalizations. Regardless of the EF. Regardless of the EF. Yeah. But there's a lot more to discuss in this. As a matter of fact, I picked this as one of the debates for the heart failure conference in January.
خليه لأن بيعطي تفضل لا خلص
السلام عليكم أسامة القصبي بارك الله فيكم في المحاضرات. Just for our audience, these people are the cream of the crop, and we are very fortunate to have them amongst us teaching us about heart failure. So thank you all very much for your lectures. My question is, in heart failure management, for reduced ejection fraction, do we chase the number, the ejection fraction, or can we just put the patients on the guideline-directed medical therapy as long as they're asymptomatic and say, okay, I'll accept a subnormal ejection fraction, but I don't have to keep chasing the above 50% number? Or should we chase the above 50% number? Thank you.
The quick answer is no. You shouldn't chase the ejection fraction. Like Mahmoud just mentioned a minute ago, he has patients with a low ejection fraction who seem to be doing well in the sense that they're out of the hospital, they're having reasonable quality of life, their NT-proBNP is relatively low, and they're essentially class 1. Now,
Are class 1 patients common in heart failure practices? They're less than 5%. So before you label somebody as NYHA class 1, you really have to exhaust questioning them to make sure that they are truly class 1, sometimes even test them to make sure that they're class 1 by doing things like 6-minute walk test or cardiopulmonary exercise testing. It's not easy for heart failure patients to be class 1, but the bottom line is if you have good medical therapy, if you treat them with devices, assuming that their EF is low to protect them from sudden death, and they're checking all of the boxes of stability, that we talked about earlier, then you shouldn't chase the EF per se.
Quick questions for all of you. First of all, do we or can we replace spironolactone with finerenone in these studies? And the question for Dr. Abdou is, as you know, diuresis depends
because of
or excessive excessive diuresis will lead to hypovolemia. So, is there any role to increase the intravascular or intra-oncotic pressure by albumin, giving albumin along with diuretics to suck all the edema fluid?
So the first question is about using MRA plus finerenone, so steroidal and non-steroidal MRAs together.
No, there is no clinical data testing the association between finerenone and MRI, but now we have more interesting results with non-steroid MRA, such as finerenone, but we couldn't associate both.
Thank you very much for everybody. Because of time, we have to, anybody from you have, I think we have to close our session, and because of time, I mean, تفضل.
Yalla, I will make it very, very short. The bottom line to your question about the use of albumin or increasing the intra-oncotic pressure, the short answer is absolutely not. This is a contraindication. You do not use it. It sounds very fancy physiologically. However, in clinical practice, it does not work. It's extremely harmful for patients, and I've seen patients die from that. So please do not do that. Makes no sense giving fluids and diuretics. That just doesn't make sense. Thank you very much.
Thank you very much, and we have to close our session. It was a useful and good discussion.